Thank you. If you've just joined us, this is the scorecard. Joy FM's, should I say, litmus test or dipstick. 23 months down the line, how is the MPP government doing? My name is Notidwa. We're looking at the health sector and what specifically is the tail of the tape. You've just heard speaking private medical practitioner with extensive experience, Dr. Yao Osafo of the Medicas Hospital. We also have with us Dr. Aaron Abuosi. He's a lecturer at the University of Ghana Business School. He specializes in health management. Honorable Robert Kugana Blem, Deputy Ranking Member, Health Committee on Parliament and MP for Binduri. And next I'm going to be speaking to Kelvin Odonko. He's a nurse and CEO of GhanaHealthNest.com, a blogger as well. Kelvin, you're welcome.
Thank you.
Right, as a nurse, I'm sure there were aspects and menu items in this manifesto that must have attracted your interest.
I mean, the everything in the manifesto was very attractive, and until now, I'm getting some awakening that a lot of them needed quite some strict questioning. I mean,
you were asleep for 23 months?
I mean, sort of. So
now you're coming to some realization.
Believing that, I mean, this will progress into transforming other areas.
Okay.
Especially when you look at the aspect of, since I'm a nurse, I'll start from the nursing allowances.
Okay.
Could it have been the reason to improve best practices in the nursing field? Was it the best way to retain nurses? Because believe you me, in this year, 2018, we're having quite a number of nurses who are moving out of the country because the UK is enabling processes for nurses to move out of the country to go. We have a chunk of nurses at home who don't have work to do. And the UK NMC is saying that if you have not even practiced for any amount of days, as it used to be that you have to practice for maybe a year or two before you can come and work there. Now UK NMC is saying that you don't need all that, just come straight. So they are enabling the processes for nurses to move out of here to go and work there.
And we are not.
And we are not. We still have quite a number of them at home, and some have resorted to working in the markets and what have you.
So this restoration of allowances hasn't done anything?
It hasn't done anything. The nursing agencies have also not been bold in, I mean, having a clear path in saying that this is what will work, this is what will improve nursing practice. A case in study. Now we have this clinical assistant, and anybody speaking on this matter has to be bold.
Right.
In the sense that resources is going to nurse assistants.
Right.
Then we have still the general nurses, the expansion, we have not seen much expansion for them.
In this instance, we're talking of nurses who have qualified and are in the profession, or?
No.
Trainees?
Under training, okay. Because these allowances were for those in training.
Right.
So we are having a situation where we are expanding nurse assistants, the training. Whereas when you look at the document that was binding this whole training thing, it was looking at having a number to support the nurses in the field.
Okay.
And when they reach that threshold, they would have to stop. But then earlier this year, there was a letter that came out that they have actually stopped training and they will rather upgrade, because when you upgrade people in the knowledge base, definitely it goes a long way to improve the practice.
Right.
But then a letter comes out and then it's withdrawn. So
there's some confusion in policy.
There is a confusion in policy.
Right. Let me just ask you this, Kelvin, before you go on to another point. As a nurse, when you heard these things, right, if you had a wish list, was this restoration of allowances your biggest priority?
I mean,
as nurses, it was made to seem to us that this is something that is killing, can I use the phrase, demotivating nurses.
Exactly.
So it was the bait.
Exactly. I took allowances whilst I was in school.
Right.
But if you ask me, and I have to be sincere, we wouldn't need allowances to keep nurses in school.
Okay.
Because then, I remember when I was going to nursing school, I picked up forms for free. And before me, I remember that they were inviting people to come and learn,
Right.
to be trained as nurses.
Okay.
But these days, the number have shot up. So could there be reformations in it? If we are increasing the skill set, definitely the diploma level may have to be upgraded, because now when you are doing your post-basic programs, it has even been pushed to a degree program. So when you finish school and you want to do a post-basic program, it's a straight degree. So then, why do we still have to continue what we were doing 10 years back, 12 years back, without having changed much, and expect best practices or practices to improve in the hospitals?
Okay. There's been some change as well. The restoration of allowances in the manifesto, which has been actualized, was to, in a sense, increase access. So get more numbers in there. But then there was also a directive that said that the training institutions should cap the number of trainees they are taking.
So when you go to my training institution, and I look at the figures, that this time around the numbers have been dropped down.
So we're losing.
But the point also is the demand for healthcare services is also shooting up because the population is increasing.
Right.
Diseases are transforming. The conditions that we used to take care of, I mean, things have changed.
Okay.
So we need much more numbers to do what we call the patient to nurse ratio, the midwife to pregnant mother ratio, the psychiatric nurse to the over 5 million psychiatric patients who are seriously ill and do not even have access to mental health facilities. Okay. So we need more than to be capped. So if the allowances is the issue, drop it off. Pull in much more of the nurses for the training.
Are you advising the government to drop this
I am thinking, allowances? I am of the
You're
belief...
thinking it's not the priority?
I am of the belief that if the allowances is limiting the numbers that has to come in to support the system, then we will have to look at it again. Okay. I will also want to quickly touch on the universal health service...
coverage.
Yes, universal health coverage. And of course, it encompasses the fact that when people need health care, and from the manifesto, the health system must be responsive. And we've been exposed badly with this no-bed syndrome. And one would ask, why did the manifesto even say that there should be an emergency center placed in Takoradi? When Accra does not have an established emergency system where health facilities are unable to communicate with each other. I mean, one would have just think through that. I mean, why was that mentioned that we are going to have? And now we also have the situation whereby private facilities were going to be partnered in a way to establish emergency response system. Right. Whilst these emergency response systems are supposed to be manned by emergency practitioners.
EMTs and other things,
But where are they? Right. Where are these practitioners?
So you don't see anything in policy direction or actually implemented policy that shows you that we're building the manpower and we're building the system to meet what we stated or what was stated in the manifesto?
There is a lot of confusion. I mean, when you go out there, apart from this Astana declaration, apart from the fact that Norway, Germany, Ghana had some sort of commendation for having stood up for global health, universal health. I mean, you hear all these accolades on the global health front, but then when you come back home, the system is very confusing. You understand? Okay. It's the reflection does not meet what is being said there. Okay. When you look at technology, the fact that we must have systems where we can be able to make simple diagnostics. Today, you can walk into big health facilities and they can't even check for some, they can't even do some lab investigations. And a lot was said about telemedicine and the use of technology in the health sector.
I'm
even not going there. Yeah. Even in the diagnostics, you have to still let patients move out of the very big hospitals to private institutions to go and do their lab tests. MRI machines are breaking down almost every week.
Okay. Wow. So this is coming from Kelvin. He's a practicing nurse. Good one at that. And Raymond, you were nodding and scrolling down.
Okay. So you asked me specifically to actually compare how much has been deposited into the National Health Fund.
Right.
And that is comparing it to the specific amount we've realized into the National Insurance Levy. And if you add even the SNIT's contribution to the National Insurance Levy, it's 1.391 billion. So, but the Health Fund reports, of course, this is being reported in the 2019 budget, 1.250 billion.
So there's a shortfall.
So yes, there's a difference between how much is being deposited in there on the expenditure side and comparing that. And this is just for the first 3 quarters of the year. That's what was reported in the budget actually.
Okay. And this is critical because, again, the funding for healthcare is something that we need to use as a measure. Like Dr. Osafo said, I mean, if you are in a certain income bracket, when you see Ayalolo, you know what it means. Right? But when you have your own car, it doesn't matter whether it's Ayalolo or whatever, you don't recognize that. So these indicators that tell us that, well, all is not well with the health insurance scheme are worrying things that we should be talking about. Doc, let me come back to you, right? The indicators are there. I have some that I looked at, right? But recently, I was on a program where I had a director from the NHIA, the authority, and I tried to ask him, do you receive all you are supposed to receive? And Raymond will bear me out. In the manifesto, it also says not only receive, but timely.
Yeah.
Right?
Yeah.
And he couldn't directly answer that. Do you get what you're supposed to get from the fund, from government? Does it come to you to disburse and do your reimbursements the way Dr. Osafo would want it? As a health management expert, how would you, should I say, rate the status of the NHIA now?
Yes.
I know you all want to give us historical antecedents, but now, is it better?
Right. It's not better. But before I elaborate further on that, I was looking for some information. I have a lot of data here. Before I even come to that, let me just give you this scenario. First of all, the per capita OPD attendance.
Yeah.
That means if you were to divide the total attendance of Ghanaians in all health facilities by the number of people in Ghana, it's dropping. From
what does that mean?
The per capita OPD
if
attendance.
It's dropping,
it's a very important. It means that people are not attending health facilities as they should.
Okay.
Okay. It was very high. It was 1.14 in 2014, which means that at least every Ghanaian attended a health facility once. That is the implication. Even though it could be several people attending the facility. You have attended 5 times, I've attended once, and they add all and divide by the total population.
Right. So 2014.
But at least they expect that globally, at least everybody should attend a health facility at least once.
Okay.
So 2014 was 1.14, which was good. And then 2015, it dropped to 1.08. 2016, it dropped to 1.06. And then 2017, it dropped to 0.98.
So the trajectory is the same?
It's dropping. It's a trend. And that is why, you see, you can't say that it is this particular government. Something is happening. Why are people not attending?
Are we losing faith in the health?
So it boils down to the health insurance, how the health insurance is performing.
Right.
And I'm coming again. When you look at per capita expenditure on health, and this is a paradox, an irony, you will see that in 2014, it was $32.8. That means that the government spends $32.8 on every citizen in Ghana.
Okay.
When you come to 2015, it's $37.6. That means it was an increase. But then dropped
marginally.
Dropped in 2016 to $24.8. But shot up by 42% to 43%, $43. Okay, sorry, I was mentioning the dollars as percentages, sorry. So you have $24.8 in 2016, which shot up to what? $43, which is 47%, 42%.
That increase, that spike is 20...
It says, yeah, 2017.
2017,
That means more than from 2014 up to 2016. So the per capita expenditure on health has been so high. What is baffling is why there is high per capita expenditure on health.
People are not going.
And people are not attending.
Is there anything...
And why the health insurance is... I'm coming to the health insurance. Is also dropping. The proportion of population with active membership.
Active membership.
Yes.
Yeah.
In 2014, it was 38%, shot up to 40% in 2015, dropped to 38.4% in 2016, and dropped further to 35.3% in 2017.
I have a question for you.
Yes, do.
Right?
Yes.
This dollar-rated per capita expenditure,
Yes.
can it be influenced by the exchange rate?
Well, but I think there are ways they go about the calculation.
Because this spike, we're spending more by way of dollars. Can it be related to, no?
Well, I wouldn't like to go there.
It's not. Okay.
Yeah, but the point the point I want to make is to come back to the very important issue, the question you asked the NHIA chief.
Right.
Whether all the monies that are received for the national health insurance is channeled through this.
Right.
And fortunately, I had opportunity to ask the former Minister for Health.
Right.
When he visited us in the University of Ghana in the business school, and I asked the same question.
Right.
And you know politicians, he said, oh, that ultimately everything goes to the national health insurance scheme. You know, so it is a question, and I told him that question I have not succeeded in getting a straightforward answer. Okay. And today I'm going to hear from the horse's own mouth.
Right here.
Does all the national health insurance levy go to the national health insurance coffers? Okay. He said ultimately everything goes.
Right. It'll be interesting, ladies.
And so you see, so that is where the problem is. The health insurance is when you go to health facilities, you will see that people are doing co-payments. Right. All right. People are paying beyond. I mean, even though you are not supposed to pay anything.
So cash and carry is back?
Yes, cash and carry is gradually coming back.
You guys don't like saying it as it is?
Yes. And I want to come back to what my colleague, doctor, was talking about the intensive care scenario. Yeah. That he expected some kind of drastic action to be taken. Right. Because this is a policy that was introduced by this government, adopting the big bang approach. Okay. And people were doubting, and it worked. But it worked at the initial stages when numbers were not yet high. It came to a point where the numbers were so high that the measures that were put in place is not possible. And they have to review it. My understanding is that the previous government started some kind of review. Okay. And some of the things we're hearing was not bad. I hear that the current government is not necessarily throwing those things away. Okay. But why it's not being expedited?
Essentially,
what is now the issue?
It is easier said than done. Okay. Right? Okay. Honorable, let me come to you because you see, again, from the figures Raymond kindly read out to us, we collect a certain amount of money, right, as a national health insurance levy. Then when we pay it into the fund, there's a shortfall. You sit on the select committee at Parliament. Where does this money go? And can we relate it when we're now looking for performance indicators for those managing the system, right? I know there are problems that are inherited or have been long-standing or pre-existing. But if we are collecting money, and Ghanaians now, we cannot dodge it. When we use services and we buy things, we pay. Now there's been some decoupling where the VAT and the other component suddenly lost on me, but it's been decoupled and actually things have gone up. Where does the money go? And how would you relate this in assessing how this government is doing, managing specifically the NHIA?
Yeah, I would say, like my colleague mentioned, that eventually the money gets to NHIS. But you know, the estimates are not actually the actuals that come at the end of the day. But the important question is the money that comes, how is it used? Let me talk about how much the previous government, NDC, owed and how much the current government is owing.
So NHIA debt.
Yes. If you look at the budget statement, it was stated that they had cleared all the arrears that the NDC left. Now, the NDC was owing about 10 to 8 months. And so if you have spent 2 years, definitely you will clear those debts. The question now today is, what is the number of months that this current government is owing?
Current arrears.
Yeah, service providers. Is between 15 to 10 months. It's between 15 to 10 months. And the sad case for me is that there are some small health institutions that have a bill of about 10,000 cedis. And you owe these small service providers for 10 months. You can imagine what these places they are prescribing. 10,000 Ghana cedis. Yet there are other institutions that owe 2 million, they owe them 2 million, 4 million, and those sort of amounts. You see, there is some selective payments. And that is why the data is not correct. We must come to a point where there is some clean slate.
The data from the NHIA is not correct. The data from the revenue agencies is not correct.
For example, when I say that there's a particular hospital, they paid up to July 2017, and then they jumped from July and paid February. From July to December,
it's still in arrears.
It's still in arrears. Then you pay February. So you have January up to November now, there's still arrears. And so that is a particular one example that I know of. And when we call some of these hospitals and they tell us, and I as a deputy ranking member have gone to the place with some institutions that owed such small amounts, just give them their 10,000 to survive. Mm-hmm. And you can imagine. And we, the NDC, at that time, we did not get the amount of money that this current government is getting. You know, the clandestine increase in VAT. All that is going into NHIS. And so they have had more money. Now they have had more money, and the numbers on the registers have also reduced. So you are dealing with a smaller group of people than the NDC was dealing with. And so these are the issues. You have received more money, and then the numbers have reduced, so you have to pay the institutions. The other critical point my colleagues talked about was the restructuring of NHIS. You know, there was a big project that was done, and you know, to see how we can run it more efficiently. Mm-hmm. Government is telling us in the budget that they have taken some measures that has improved efficiency in NHIS. But as Ghanaians, we need to know what these efficient measures that were taken so that we can agree with them and move forward.
Okay.
I want to introduce something that the good old Professor Atta Mills mentioned sometime, which most people poo-pooed. And that was the issue of one-time premium. Mm-hmm. What does it mean to have one-time premium? If, for example, right now, we cannot tell whether premium collection, the cost of collecting premiums from people, whether it is not more than the amount of money that we receive as renewals and then registration for NHIS. We've set up a huge bureaucracy that is spending more money to manage themselves than manage the health of the people. And so we need to look at it critically. It is intellectual. We need to analyze certain things rather than poo-poo them. Because for me, basic primary health care can be free.
Okay, honorable.
Can be free. People who pay national, SNIT, you can have graduated insurance. So that when I go there and I pay to that, the sort of services I receive is certainly different. If I work in the gold mines and I go to insurance, the sort of services I receive should be different. If we want to do it as we are doing it, we have to do it right.
All right. Honorable, I get the sense that you're not quite happy with this government's management of the health sector and indeed specifically of the national health insurance. I indulge you more because as somebody with expertise in the area and also a deputy ranking member, but I want to let our listeners also know this is not intended to go partisan, and especially when I don't have direct governmental representation here. And I don't want... Pardon? It started long ago, eh? It's been partisan, eh? No problem, right? I feel the spirit in the room, but it's okay. But again, also, let me come back to some of the other manifesto things very quickly. Increase our capacity to train the requisite health personnel that we need to man and run our health systems. And this also looks at training institutions, the nursing training colleges, you name it, the medical schools, etc. Are we seeing anything in this regard, right? Let me come to you, Kelvin, and then I'll come to Dr. Osafo as well.
So, I mean, like you rightly said earlier, there is a system of sort of capping in the NTCs, in the nursing training colleges, where you find out that the numbers are being checked as to how many should be admitted at a time. Now, which means that definitely by the time they come out, there's also going to be some sieving because after writing licensure exams, the numbers is also going to be slashed. Yes. And that number which has been capped will still be dropped again. Before they will have to...
Was it not like that before?
Yes, but then when you look at the transformations in the health system, epidemiology, I mean, the number of patients, the population and all that, the numbers was sort of meeting it at a point. But now you see clearly that the situation on the ground is going faster than the human...
So we're not building the human capacity or the personnel numbers to meet the demand.
Well,
that's exactly what you're saying.
To this point, not yet. Though some measures have been put in place, like one, now post-basic programs have been upgraded from just a post-diploma to a degree program.
So that's a good point.
Right. Which also means that when you are going for your post-basic programs, you are going to spend a little more time under training. So now the numbers have been sort of limited. We are limited in a way to respond. But then when you look at the figures also, we are being told that the doctor to patient ratio is still, we haven't still been there. It hasn't still appreciated. But the nursing aspect have appreciated. But this is the thing. Now, nurses are being supported, the numbers of the nurse practitioners is being supported with the assistants. So instead of the specific professional trained registered nurses, you're having these two all being merged together and representing the number.
So are you saying that the number we see, therefore, is spurious? It's not the actual thing?
That is not the actual thing.
But then
if we have to be specific,
nominally, it would show an increase.
It will show an increase.
But then the categories
when you go into it, trained registered general nurses midwives and all that, the specific numbers we have still not appreciated much.
Okay.
Because for now it's being backed with these nurse assistants. But when you look at, I've just realized also that the Nurse and Midwife Council is also introducing programs where those assistants, the assistants that are being trained, will also now have to elevate.
They can elevate or upgrade themselves.
Upgrade themselves. So that is where I still have my confusion. Because, to be honest, the registered general nurses, the style of training have been quite a long time. Push it up there. Upgrade it. Now, can we halt a little on the nurse assistant program so that those who are already in could be upgraded to join these numbers? When you are going for your post-basic programs, if you have to go and do these fellowships, now we also have these nurse fellowships that you can equally go. The college, we also have a nurse.
But Kelvin,
college.
It sounds like you're seeing some policy movement. Just that you're confused as to its intention and its objective.
So I'm not, saying there's a zilch performance.
Right.
But then again, we need a drastic move.
Okay.
Because for me, the nursing body have been dragged in a way. Whereas when you look at the backbone, when you look at the numbers, nurses could cross over 50% of the health workforce.
Okay.
And they are located in very vital areas. Very vital areas.
So you expected to see more policy push in that direction?
In that direction.
Okay, well taken.
That is supporting the nurses.
Well taken. Dr. Safo, you have to engage and recruit health personnel, right? And you want quality personnel, right? Are you seeing in this government's performance steps and policies that are going to guarantee you that we'll get better quality? And for those of you, I'm sure we'll take some questions shortly. So, Dr. Safo, are you seeing that the policy direction aligned with the manifesto is achieving something in this regard, health personnel?
Right. So again, the manifesto was big on training of healthcare personnel.
That's right.
Right. Very, very good. And it wasn't broad enough. It didn't go much into details in terms of the health personnel, because health is broad. So you've got the allied health professionals, you've got the pharmacists, and you've got nurses, then you've got doctors. So if you want to look at that broad area of training, then it cuts across about different people. So let me start with the doctors. I'm much more comfortable in that particular area. One of the things that has been done is the expansion of the what we call the housemanship training centers. So once a doctor graduates from medical school, you undergo a period of housemanship training. During our time, many years back, it was just Kolebu Teaching Hospital and then Komfanoche Teaching Hospital, where you can have that training, where you work under a consultant so that you are guided and then they deem you safe to release to the population.
Consolidate your skills, etc.
Yes. So there was a limitation as to how many doctors you can graduate if you have only these two training institutions. So over the period, and I think over the past 2 years, that has been broadened to rope in other training institutions.
And therefore,
where they
enhance the numbers.
And therefore enhance the numbers.
Okay.
So if you've got a lot more institutions where the doctors can have their housemanship training, then you can recruit a lot more into the medical school and train a lot more doctors. So that the fact that they have roped in a lot more training institutions for the housemanship training for doctors is a plus.
So that's walking the talk.
That's walking the talk.
Doing something you said you do.
Exactly.
Right. Okay.
So that's helpful. Again, part of the reasons why sometimes young doctors are afraid or refuse postings to the so-called deprived areas is that there are a lot of one-man stations. So you are sent somewhere and you are the only doctor there. And you are fresh. And our work, it needs a lot of experience and confidence.
Right.
So you're taking somebody to surgery and your hands shouldn't shake when you hold the knife. But that comes from a lot of confidence, and confidence comes from doing. Or if you have a big man behind you, say, oh, okay, my boss is around. If I get into trouble, I can call somebody, then it helps. So again, there's been a policy of trying to post a lot of specialists to some of these so-called deprived areas, district hospitals, so that they can all have specialists. If you have a specialist or a senior doctor there, then posting a junior doctor to that place, it makes it more palatable, it makes it easier. And then there's difficulty of doctors refusing postings. And most of the time we get a lot of bashing in the media. You don't understand why the person doesn't want to go and serve in the honorable member, I say, so let me Binduri or something. And it's not because it is Binduri or it is far away. It is most likely because you go there and you realize that if I get into trouble as a fresh doctor, I don't have any senior person to call to assist me. And that is very, very difficult, and sometimes it is a scary thing. So the fact that they are posting a lot of senior...
Are they posting with any meaningful intervention or just posting with the hope that you are committed? Well, I've handled situations where a person or personnel are posted, there's no accommodation, they are worried about whether the children will get to school. In other parts of the world, they make sure these things are provided, so it serves as an incentive. What I'm asking you essentially is that in this government's program of work and policy direction, are you seeing specific, meaningful interventions that do what you're saying?
Right. So,
other than just the posting?
Right. So the first thing has to, so you've mentioned the other aspects of why the postings might not be successful. Yes. But one of the things too is what I have described, that the lack of senior people in those institutions. So I think now they are getting a lot more of that, and because the Ghana College of Physicians, which is a postgraduate training institution, is churning out a lot more specialists, they are now getting to post a lot more people out there, and that also makes it easy. So I'm talking about the education bit. Because if you got a senior person there, then it's easy for you to train and also for you to learn. And so that is also helpful. But as you're saying, it should be holistic. It shouldn't just be that a senior person is there. But then there are other conditions that you need to meet before you get posted there. When it comes to training of other personnel, I'm a bit worried about the quality that it's coming out that's available for us to hire.
Technicians, physiotherapists, pharmacists, what? Oh.
Yes, and in particular the nursing front.
Right.
I'm not quite sure what is happening, but the quality doesn't seem to be the same. And I do a lot of recruitment, and I get a lot of applications. So again, it goes to speak to the unemployment situation. So there are a lot of nurses who are staying at home, who've been staying at home for a long time. I haven't seen the numbers of application go down for me to think that, the recruitment. Recently, I heard the Minister of Health mentioning the number of people who have been recruited. We've also heard about the NAPCO initiative. And they're going to recruit a lot more personnel under that initiative, under the health aspect. So people are going to be recruited. But we've been getting a lot of applications over the past 3 years. People looking for work. And the bulk of them are nurses who have been staying at home for 3 years, 4 years, without any employment.
So essentially that situation hasn't changed much.
It hasn't changed much, but I think the NAPCO initiative, and I think people can discuss the politics of it, whether or not that is real employment or not. But I'm happy to have them.
The Nation Builders Corps.
The Nation Builders Corps.
Which has a health component.
Which has a health component. And they are recruiting some of the nurses or healthcare workers under that initiative. So that's a very good initiative. Rather than stay at home, you get recruited. It's a training program as well. And if you work in an institution and they are happy to have you, then you get the opportunity to be engaged. So again, that initiative is an initiative by the government, and it is helpful in that regard. Whether or not that qualifies as permanent employment, as people want to look at it, well, that's a different thing. But I think that trumps staying at home.
Right. For all my panelists, I'm going to say that start getting into your mind a measure, an index, a score, right? It's good that we talk. And for you, the audience here, it's about time we took some questions. So I'm coming to you, right? Just indicate to me and make it snappy to the point so that we can identify who is supposed to address it and then we deal with it. But before I take those ones, or Kofi, are we ready for that? The microphone is there. Right. I just wanted to ask Honorable, there are a few things that have been flying around for too long. We had the no-bed syndrome. We know we have only 55 and a half functional ambulances, whatever that means, right? We've lost a vice president, and the issue of ambulances came up again and again and again. Are we seeing any movement in these indicators? Emergency healthcare, you mentioned the CHIPS compound, you felt we're not doing enough as stipulated in the budget. But some of these critical things that people worry about, are we seeing movement 23 months down the line?
Yes, we are seeing some government taking some measures to improve the situation of ambulances in the country. I know that some ambulances have been ordered.
Okay.
And very soon, districts will have ambulances. But the other issue is we had some 30 that was wasting. And so whatever the methods of procurement, they were already here, and they've been here for long. Eventually, we'll pay for them. And so why don't we fix them and get them to work so that at least people would have access to them when they need them. The emergency centers, it's also well spelled out in the budget, which is critical. But I would touch the issue of employment.
Yeah.
Just recently, bonded nurses wrote a petition to the president, and they are just about 6,700 and something. Bonded nurses mean those who went through government institutions and they signed a bond.
And therefore can't work anywhere else.
Yes.
Yeah.
And 18th October, they have not been responded to. And the health committee were meeting on it. And so it is important that when you say you've employed 80,000 people, yet we know that a critical mass for employment is the nurses because they played a critical role during the last elections. And they have skills. My good friend, the doctor, talked about the fact that skills are deteriorating because if you sit at home, your skills will deteriorate because you are not practicing what you're supposed to practice. Again, it also, apart from the nurses, doctors, foreign-trained doctors, they've come back from China, from Russia, Ukraine, and the rest. Most of them cannot get employment because they need to write an exam and pass, and it is difficult for them because the training.
Are you suggesting we should just let them walk in and then just...
No. For me,
it's a requirement.
It's a requirement. But for me, what is just, what is fair, what is decent, is to allow them write the same exam like those who are trained in Ghana. Full stop. But when those who are not trained in Ghana, I have interacted with them, so I know what I'm saying.
But this predates.
No.
It predates the MPP, right?
No. This is national policy.
Yes, but the exam and the criteria for returning medical professional predates this thing. So I won't allow it to contaminate the discussion. But let me see if there are any hands up, Ben. If you've just joined us, this is the health segment of the Scorecard. We're reviewing the performance of the MPP government, and I have on my panel Honorable Robert Kuganablem, Deputy Ranking Member, Health Committee of Parliament, and MP for Binduri constituency in the Upper East Region. Dr. Aaron Abuosi is the Senior Lecturer, University of Ghana Business School. He specializes in health management. Then I have Dr. Yao Osafo. He's a private practitioner. He runs the Medicas Hospital in Mampong. And of course, Kelvin Odonko is a practicing nurse and an avid blogger. Madam at the back, just identify yourself and ask your question.
Yeah, I'm Elizabeth Kurasari. Thank you very much for this opportunity. I'll speak to the NHIS. I'm a beneficiary of NHIS, and I will say that it's a very good scheme.
Right.
Seriously, recently I had a surgery just with NHIS card, a surgery that is costing over 2,000 in Accra here. I had it in a very small village out there in the eastern region, in the hospital, and it cost me nothing at all.
Did you migrate because of the procedure?
Yes, I had to go to that hospital because of the procedure.
Is it because you registered in that?
No, you can use your card anywhere at all.
Okay, interesting.
Yes. But then one of the panelists mentioned that the scheme, the number of people users is going down. Ever since this scheme, its inception in 2000 and something, renewing and registration is a hell. Seriously, nothing has changed ever since from regime NDC MPP. Nothing has changed.
So it's frustrating to renew.
It's very frustrating to renew.
Right.
Frustrating to get a new card. I have 4 kids on the scheme, and anytime a card expires, my heart keeps beating. Okay. Because you have to go there for weeks before you can get one card renewed.
Right.
And I don't know, it's a simple thing. Recently, there was a number circulating around *842# *10# for renewal. You do it, and the only thing it will tell you is that you have registered. Nothing else. You can all try it. It will tell you have registered.
You have registered. Agbena.
Nothing else. You cannot renew.
Right.
Even though it's stated that soon you can renew with mobile money. When?
So the essential point is that it's a good scheme, and I don't think anybody here has suggested that.
Yes,
but
it's very fantastic.
Renewing your membership is a problem.
Yes.
Okay, so it's not a question to...
No.
Okay, well taken.
Okay.
Right. Okay. I have other hands up. Yes, sir. Oh, okay. Yeah, there are hands here. Let's take a few as quickly as we can. Yeah.
I think what I also have is just simple. In fact, in as much as we are here to ask questions, but we can also take the opportunity to make a little contribution.
Okay.
I think the little contribution I will make...
Can you just kindly identify yourself?
Yeah, I am Abdurrahman, PhD scholar. Or student. I'll say PhD student. In Ghana here, you say student.
What are you pursuing?
Yeah, sustainable development.
Okay.
Yeah. Yes, in fact, I have, as a public servant, once governor is not represented here, I want to take the opportunity to make a little contribution. Okay. There was a statement which was made in connection with the National Health Insurance about the promulgation and also the implementation after the 2000 elections. In fact, it was just by chance and coincidence that I happened to be a campaign officer to one MPP aspirant in the northern region.
Okay.
And I knew, as a campaign officer, you need to know a lot about the manifesto more than the aspirant.
These are nurses who have been certified by the
please?
Nursing and Midwifery Council of Ghana. They have been given licenses to practice. So all those things will be checked before you are posted under the health module of the NAPCO. I think the issue, which I agree with my colleague, is the remuneration. Because he mentioned the fact that, yes, when you start as a staff nurse, you start at a certain salary scale, if you are going to the normal recruitment. But this is a NAPCO initiative, which is, there's a backlog, and they are trying to get that backlog. It's an intervention, so you're trying to get that backlog something to do. The longer they stay at home, the more rusty they are going to become, and that skill is going to be lost. So they are going to be posted. Hospitals have been asked to put in applications if you want one. So on that score, I think it's a good initiative to help address the backlog that we have. It's a stopgap measure.
Stopgap measure.
Nothing stops anybody from applying so that in due course they are... Of course.
It's okay. So we're not going back into discussion. Stopgap measure for that specific restricted purpose, you are okay with it. Now give us a stopgap score.
Right. So in terms of the score, it's very difficult. Let me tell you why it is difficult for me. I'm an investor in the health sector. I bring an ambulance into this country, and I had to pay a lot of money at the port to clear the ambulance in a country where you still have 54.5, as you call it.
Don't follow
the
me.
half. I don't know. Ambulances in this country. Right. And my business is also in a part of the country that you can label as deprived, outside of the Accra, Tema, Kumasi-centric designation that one of you gave. Why do I have to pay so much in terms of duty to bring in an ambulance, to bring in an X-ray machine, to bring in an endoscopy machine, all to improve the quality of service delivery in Mampong Equiapem, where we are located? So in that score, I think a simple policy initiative to waive taxes and all of that can be done by the government to encourage the private sector to invest more in the healthcare sector, and then also employ more people.
And then your score.
In that regard, in terms of helping create more jobs in the healthcare sector by helping private investors, I'll give them a 4 out of 10.
4 out of 10.
In terms of the interventions to get the backlog, of healthcare professionals and then train a lot more, I'll give them a 6 out of 10. Overall,
now you're getting a transcript.
Yeah. Overall, I would think that a 5.5. 55%.
Okay.
In terms of the various things that they are doing, and I'll share with my colleagues' sentiments as well, that it will take a bit more time for some of these interventions to begin to yield fruit. So 5.5 out of 10.
Right. Thank you very much. My panelists, we know who they are, and thank you as well. It's been a refreshing, should I say insightful as well, discussion. It doesn't end here. And Joy did not design this to be conclusive or scientific, but it gives us some crude measure of what is, should I say, perceived as the performance of the NPP in the health sector. Our panel is not totally inclusive, and there are so many things you can say, but we've got a sense of what is going on, and we've raised the issues. Thank you once again, my panelists, and of course, Raymond, for feeding us with the facts and the points. And thank you, our loyal participants here and audience here, and of course, our listeners, right? This discussion has to go on. After this, there's another segment on the agri sector, right? Another critical sector, and we must measure by all means. Anything that can be measured can be managed. So that's why we're doing this. Once again, thank you very much. My name is Notedua. It's been a pleasure.